My name is Jeremy Myers, and today I'll be presenting a lecture I gave at the McAninch Visiting Professorship in 2023 at University of California, San Francisco on renal trauma. Specifically, the talk is entitled Evidence-Based Treatment of Renal Trauma and Renal Trauma Grading, Insights from the Multi-Institutional Genitourinary Trauma Study, or MiGUTS. As far as conflicts of interest, this study was supported by the American Association for Surgery of Trauma Multi-Institutional Trials Committee, and I was PI for the study. They supported database development for a centralized database. They also advertised the study on their website, and they preferentially published manuscripts from the study in the Journal of Trauma. MiGUTS was a collaboration between University of Utah Health, the AAST, and the Trauma and Urologic Reconstruction Network of Surgeons. The overall study looked at renal, bladder, and urethral trauma, and today we'll be talking about renal trauma specifically and the study findings. So to talk about MiGUTS, it was a two-phase trial as far as renal trauma. In phase 1, 14 centers ultimately joined the study, and we collected prospective data on demographics, trauma details, etc., on 431 patients who were enrolled with high-grade renal trauma, which was defined as ASD grade 3 through 5. The aims of phase 1 of the study was to establish contemporary nephrectomy rates and then look at the factors associated with nephrectomy and create some type of bleeding risk calculator. Phase 2 of the study was retrospective, and 7 centers enrolled. 750 patients were enrolled in the studies, and again, it was in high-grade renal trauma. The aim of study phase 2 was to externally validate the renal trauma nomogram we had created in phase 1 of the study. So I'm going to be talking about our findings in context of a case. This case was in a 22-year-old male who presented as a level 1 trauma activation after being transferred to University of Utah from the Solitude Ski Resort. And he had fallen approximately 65 feet while snowboarding off a cliff. He had a good GCS on arrival, but he did complain of shortness of breath and severe abdominal pain. The GU physical exam, he had hematuria when a catheter was placed, and there was no apparent pelvic fracture. He had a positive FAF. Initially, he was hypotensive, tachycardic, but responded to crystalloid and 4 units of packed red cells, and he was relatively hemodynamically stable with this resuscitative effort. He went to the CT scanner, and a trauma CT was obtained. So what are important aspects of a risk calculator for hemorrhage? And we thought about this with 2 important parts. One is clinical factors, things that are available during the evaluation of a trauma that increase risk or are signals that patients will need intervention. And the other was radiologic findings on a CT scan that indicate a kidney has a more severe injury and more likelihood of intervention for renal hemorrhage. So what are the clinical factors you can think of? You know whether the patient's in shock. You generally know what the mechanism of injury was. Were they shot or were they run over, a blunt mechanism? You can tell other injuries based on the CT scan or a secondary survey. But some things that have been incorporated in risk calculators in the past for renal trauma aren't really very helpful. And those are things like the number of packed red cells within 24 hours. You don't know at the time of the injury how many packed red cells a patient's going to use in 24 hours. Hematocrit is something that's very variable, and it depends on the patient resuscitation, the rate of bleeding, and hemodilution, and how fast that occurs. And then the overall injury severity score is highly predictive of the need for intervention, but that's something that's not used clinically very often, and it's something that's generally calculated well after the trauma by trauma coders who are putting patients in a trauma database. So in our first study, or one of our first studies, we looked at these clinical factors and the risk of one specific bleeding intervention, which is nephrectomy. In this study, it was phase 1 data, so 430 patients. The AST grades were, as you would expect, over 50% was grade 3, a third were grade 4, and then a small number were grade 5 injuries. There were 55 nephrectomies, or 12.7%. That's actually a very low number. If you look at more older studies that we're talking only about, maybe 10 or 15 years ago of the National Trauma Data Bank, nephrectomy rates were in excess of 25%. So there really has been an adoption of conservative management over time. Grade 4 injuries had a 15% rate of nephrectomy, and grade 5 injuries had a very high rate of 62%, not surprising given the nature of the injuries. Looking at all those clinical factors and how they correlated to interventions, we found those 3 that we were really interested in correlated very highly with intervention. So if they arrived in shock, if they had penetrating injury, and if they had other concomitant injuries, which we defined as other solid organ injury, gastrointestinal injury, pelvis fracture, or a spinal cord injury. All of those increase the odds of needing a nephrectomy substantially. So back to our case, the patient gets this CAT scan, and you can see this massive retroperitoneal hematoma. The kidney's pushed superiorly. And then you start to see vascular contrast extravasation going down kind of within Gerota's fascia, maybe without Gerota's fascia a little bit. And then you see the laceration at the top portion of the kidney where a lot of this active extravasation is coming from. What does this look like in axials? You can see the active vascular contrast extravasation, and then this sort of curvilinear laceration that travels kind of along the contour of the kidney. And, it's fairly innocuous laceration, really, other than the fact that it's bleeding like crazy. So putting the nomogram together, these clinical factors were highly associated with intervention. And now what about the radiologic factors? And this was first popularized by Dr. Mori and Daniel Duggy. And Dr. Mori was a fellow here when Jack McAninch was AUA president. And so he did 2 years of fellowship, which a lot of the fellows surrounding that time were quite jealous of. And so he worked his career mostly at Parkland Hospital and UT Southwestern, and was a professor there, and has recently moved into a more private practice setting. Dan Duggy was one of his fellows, and he's now a professor at Oregon Health Sciences University, and he focuses his career in reconstruction on gender affirmation surgery. So they first popularized the idea that radiologic findings could be highly correlated to need for intervention. They looked at grade 3 and 4 injuries that were almost all blunt injuries. There were 102 patients seen at Parkland that had CT scans. And the interventions for bleeding they counted were nephrectomy, rhinorrhaphy, and angioembolization, similar to our study that I'll show you in the future. They found 18% intervention rate for bleeding, and they found 3 highly associated factors for interventions for bleeding. These were a perirenal hematoma of greater than 3.5 centimeters. Another factor was vascular contrast extravasation. They call that intravascular contrast extravasation, or ICE. We call it VCE. That dramatically increased the odds of intervention. And then the complexity of the lacerations. If lacerations were medial, or if there were complex multiple lacerations like a lateral and medial laceration, those all increase the odds of intervention. In one of our first trauma studies, when I got to Utah, we looked at regional application of these risks, associated risks, and we found that they were highly associated with need for intervention. The problem with these and a lot of other studies is this was our rate of intervention, 8. So I'm not sure how we got this published in Journal of Urology, but I was grateful we did. But you can't really tell much based on 8 interventions about what's significant and what's not. Other studies were similar. The middle study with 14 is from Harborview, and in 18 interventions included some interventions for urologic leak, like stents, etc., and that was from Keith Rourke at Alberta. So the power of our study looking at these radiologic factors is we had 47 interventions. So we had a much larger cohort of patients. This was phase 1 data, and it was 326 out of the 430 that had CT scans to evaluate for these factors. We counted the interventions as similar to the other studies, but we also added renal packing, which was just a few patients for hemorrhage. What were the factors that were associated on a simple comparison? We found that hematoma rim distance, vascular contrast extravasation, the extent of hematoma, and that's whether it's pararenal, meaning that it came across the midline or it went below the aortic bifurcation into the pelvis, the depth of laceration, and the number of lacerations. So in a multivariable analysis, the most important factors were hematoma rim distance. For every centimeter, it increased the likelihood of intervention by 15%, and then the presence of vascular contrast extravasation, with the other factors not being significant in this multivariable model. Another thing from this study that we were able to do is see the best fit for cutoffs in hematoma rim distance and lac size, and we found this was 3.5 centimeters, exactly the same as our regional study, and also exactly the same as Al Mori's study. And then the lac size was 2.5 centimeters, and these come into play later with our proposed changes for AAST grading. So in other words, if you had a hematoma rim distance greater than 3.5 centimeters, you had an overall 6-fold increased risk in intervention. And if you had a lac size greater than 2.5 centimeters, you had a 4.4 fold increased risk. So putting these two things together and creating the nomogram was the next part of the study. And so this was, again, with phase 1 data, creating the nomogram, all of the patients with CT scans. So it only applies to patients that have radiologic imaging. And then we use this complex statistical method for creation of nomograms called stepwise regression, where essentially add a lot of factors and then you take away factors, seeing how they contribute to the overall fit of the model. And we found the factors that contributed in the clinical were just what we suspected. They were shock, mechanism of injury, concomitant injury, and the radiographic factors were the presence of VCE, the hematoma rim distance, and what the extent of the hematoma, if there was a pararenal hematoma. So this was nicely predicted need for interventions of 0.83, which was really quite good for modeling. So back to our case, this patient has VCE. The patient has a pararenal hematoma that extends across midline and below the aortic bifurcation. And the hematoma rim distance was 8.5 centimeters. So he arrived in shock. He had VCE, pararenal hematoma, 8.5 centimeters, so he had an 85% risk of need for intervention. Now, I don't think in trauma centers you need a nomogram to know whether you need to intervene. Trauma surgeons and urologists are very adept at assessing shock and assessing the need for intervention. But I'll show you one way that this could potentially be very helpful. This is a study from Judith Hagedorn, who did her fellowship with Hunter Wessels, who was a McAninch fellow. She did it at Harborview, and she works there and is now the program director there. So she looked at 77 isolated low-grade renal trauma patients, and 50% of those patients were transferred from outerline facilities. And University of Washington's a lot like University of Utah. At Utah, we cover this vast geographic area in the Intermountain West. And that geographic area spans approximately 5% of the geographic United States. And we have 2 fixed-wing aircraft and 5 helicopters throughout Utah, Wyoming, and Nevada for transfer of critically ill patients. Similarly, Washington takes patients from Alaska. So in these low-grade trauma patients, there were no interventions other than 3 patients received blood and were in the ICU due to the receiving blood. All of the patients were discharged at 48 to 72 hours upon arrival. So this points to probably overutilization, and that's where this nomogram could come in. You could look at a lower level trauma center, say in Idaho, that's considering transferring a patient, 8 hours by car or a fixed wing flight to University of Utah. And you could say you actually have very low chance of intervention on this renal trauma. You can safely observe the patient at this hospital. So it's maybe better for resource allocation. So what was our second phase of the study? And that was to externally validate this bleeding risk calculator. So this was the external validation study. Again, we used the 750 patients retrospectively at different trauma centers to validate the study. And there were 570 that had CT scans. And the nomogram was applied, and we looked at the area under the curve and modeling our nomogram. There were some differences. The patients were younger slightly in phase 2 or phase 1. And then there was higher ISS in phase 2 of the study, 22 versus 27. So slightly different patient groups, but the injuries, the number of injuries within each ASD grade were very similar. So we found gratifyingly that the nomogram performed exceptionally well with an area under the curve of 0.88 on the external validation. So now I'm going to pivot a little bit to AAST grading and how we can take the evidence that we learned, especially related to radiologic factors, and apply that to renal trauma grading with an update in renal trauma grading. So these are as a diagram of what we commonly think of for grading of renal trauma. And just to remind you, Dr. McAninch devised this grading system with E.E. Moore in 1989. And, it was based on best evidence at the time, and it was used for decades until it was updated in 2018. So it's quite incredible, a 30-year period that this was our standard for grading renal trauma. I want to talk a little bit about E.E. Moore. He was head of trauma at Denver General, where I spent a lot of time in my training. I did a 6-year program at Colorado, and in general surgery and urology, we spent a lot of time here in this very foreboding-looking building. E.E. Moore was quite a personality, and I would love to hear from Dr. McAninch about how he got along with E.E. Moore and what professional and personal interactions were with him. He had a very gravelly voice and this very distinctive handlebar mustache. He ran the Leadville 100 several times, which is a 100-mile foot race at 10,000 feet or higher in Colorado. And the rumor or the legend was that he would stop periodically, at least once, and drain his knee with a syringe and a needle because he got such a knee effusion during the race. This is him demonstrating gunshot wound ballistics by firing a gun in a gun range in Colorado. So it was really quite a privilege to know him and to work with him during my time at Denver General. So this is an illustrative CT scan that shows some of the problems with AAST grading. So how would you describe this laceration? This is a deep laceration through the cortex of the kidney towards the hilum. But what grade of injury is this? And the answer is we don't know. There's no extraocular images to sort of determine whether this is a grade 4 injury versus a grade 3 injury. And that's a big problem because in many trauma centers, extraocular images are not routinely performed. So here's the scan, and here's the extraocular images, and you can see that fluid that's anterior to the kidney is probably mostly urine, and this is a grade 4 injury. although it may not have a very high rate of intervention, at least for renal hemorrhage. So this is some data. We did a study that showed the optimal time for expiratory imaging, which I'm really proud of. It was one of the early studies that Soren was able to complete. But one thing in the study is that expiratory imaging was only done in 65% of patients with high-grade renal trauma. So really suboptimal adherence to guideline statements about assessing renal trauma. So in level 1 trauma centers across the US, expiratory images aren't being done, and you really can't assign a lot of grades to renal trauma. So this is our patient, our index patient. You can see the patient has VCE and this sort of curvilinear laceration. And what would you grade this grade? And this patient would probably be graded as grade 3. They have a renal lac greater than a centimeter. They have active bleeding that's confined to Gerota's fascia. And you might argue, no, it's outside of Gerota's fascia, but the active portion of it seemed like it was within Gerota's fascia. And so is it the hematoma that's big or the actual active extravasation? So it's a grade 3 or grade 4 injury, but there's a lot of indistinctness there or a lot of ambiguity there. And in fact, there's lots of examples with AAST grading where here's the increase in grade from grade 3 to grade 4, but actually the bleeding risk is highest for the grade 3 injury. Now we know AST grading is highly correlated with risk for intervention, but could it be better? So in one study that we did, we looked at the update that was done in 2018, and the update was in a very good attempt to describe renal trauma better, to better characterize how renal traumas kind of present radiographically and sort of provide a better tool for trauma surgeons. So we took all of the patients and classified them in the 1989 system and then the 2018 system. And we found the effect of the 2018 system was largely to move a lot of grade 3 renal trauma up to grade 4. So grade 5 remained relatively stable. So there were less grade 3 traumas and more grade 5 traumas, which were more heterogeneous. And the primary reason that occurred is this segmental kidney infarct or segmental vein or artery injury. And so here's a segmental kidney infarct with no laceration really present, no blood around the kidney, risk of any intervention, but this was now a grade 4 injury. The revised AST was still highly predictive. You can see the relative risks or odds ratios there of interventions. On the right side for grade 4 compared to grade 3, it was 3-fold. For grade 5, it was 12-fold. But when you looked at the overall fit, there was no difference between the two, the 1989 system and the 2018 system. So there was maybe an opportunity here to improve grading. So what about segmental kidney infarction? That was one of the things we looked at first. So we used phase 2 data with CT scans, and we grouped the patient by isolated segmental kidney infarct, which we called ISKI. Being in Utah, you got to have a great acronym. And then the other group we called non-ISKI, and those were grade 4 injuries that had segmental kidney infarct, but had other reasons for being a grade 4 injury, like urinary extravasation, etc. And when we looked at simply bleeding control interventions for ISKI, it was 7%. For non-ISKI injuries, it was 21%. So a real difference there in gross risk. And then when you dropped all of the ISKI injuries down to grade 3 from grade 4 and looked at the modeling, there was no difference between the two. So you didn't degrade the model by making that change potentially in AAST grading. So another thing that kind of bothered us was the concept of shattered kidney and how that was treated in grading. So the way it's graded is grade 5 injuries are graded as shattered kidney with loss of identifiable parenchyma. That's kind of ambiguous. And so what we did is described a shattered kidney with the radiologists that were in the study as greater than 3 segments of kidney separated by blood or fluid. So a much more descriptive and definite description of shattered kidney, definition of shattered kidney. So we used all the data that we had in phase 1 and phase 2, and 41 of the patients, or just under 5%, had shattered kidney in the series. And then of these 41, 61% underwent bleeding intervention. Those interventions were nephrectomy primarily, and they also underwent angioembolization at a certain rate. Some patients had angioembolization, then nephrectomy, and that's why it doesn't add up perfectly. Now, when you looked at VCE, 28 out of the 41 patients, or almost 70%, had VCE. And if you looked at the gross interventions between the two, those with VCE had a nephrectomy rate of 61% versus 8%. And then any intervention for bleeding was 75% versus 30% in those patients without VCE. So to summarize, the definition of loss of parenchymal anatomy, which was 18 of those patients, the risk ratio was 4.9 for intervention. If you looked at our definition and the presence of VCE, the risk ratio was 7.2. So we proposed another change to this AAST grading. And so this is a Sankey diagram, and it's a little bit hard to interpret, but these have become really popular for good reason. They're very illustrative. So on the left is our definition of shattered kidney in the study, and then the 2018 definition, where 18 of the patients would have been defined as shattered kidney. And then our proposed revision to AAST grading, where we said, if you have shattered kidney and VCE, you're grade 5. If you have shattered kidney, no VCE, then you're grade 4. And you can see what happens. There is a lot more grade 5 injuries with VCE, and then there's less grade 4 injuries. So, you know, it's seems to fit the risk of hemorrhage. And if you look at that bottom line, the AUC was 0.71 for the 2018 versus 0.75 for the revised OIS score. So what about urinary extravasation and the change we proposed there? We had a total of 17% of patients that had urinary extravasation in phase 2 of the study. And if you looked at the reasons they were classified as grade 4 and only urinary extravasation as the reason for grade 4, it was 50% of the patients with urinary extravasation were grade 4 just because of extravasation. So really a lot of the patients. You know, another important aspect here that emphasizes the lack of compliance and the difficulty of using urinary extravasation as grade 4 is that 40% of patients did not have expiratory imaging within 24 hours. So even a little worse than we saw in phase 1 of the study. And then in that study where we found that that delay ideally was about 9 or 10 minutes, another 50% of the patients with extravasation that did get delays did not have adequate delay. And so if you put those together, 70% of the patients did not have adequate expiratory images to say whether they had a grade 4 injury or not. So a really big problem in using this to really differentiate between grade 3 and grade 4, which happened in about 50% of the patients. So what about bleeding interventions in patients with urinary extravasation? In grade 3 injuries, it was 6%. And urinary extravasation that were grade 4 only because of extravasation, it was 7%. And in those patients that had other reasons to be grade 4, the intervention rate was 16%. So this really provides good rationale for dropping urinary extravasation alone to grade 3. Okay, so putting together all of these changes, this is what we're working with the AAST right now on creating a document that proposes a new grading system. So no change in grade one. In grade two, we say 2.5 centimeters or less as far as the laceration size, and then a hematoma rim distance less than 3.5 centimeters. Grade three, and likewise greater than 2.5 centimeters for lac size, greater than 3.5 centimeters for hematoma rim distance. And then segmental kidney infarct or vascular injury without VCE is in grade three. And then patients with urinary extravasation that don't have other reasons to be grade four are counted as grade three injuries if they have adequate imaging. Grade four, we still included UPJ disruption because almost all those patients will have an intervention. And then near complete or complete kidney infarction without VCE, and then any VCE besides those in grade five. And then we also made another important change is we got rid of shattered kidney. I think shattered kidney kind of creates a situation in a lot of people's brains and a trauma surgeon's brains that this kidney is just splatted. It's irrecoverable. And as we've seen, a lot of them without VC can be managed conservatively, and they do actually. We have several series of CT scans where they actually really repair themselves, and they're quite functional afterwards in a lot of cases. So rather than shattered kidney, we use the term multi-fragmented kidney. And again, that's greater than three segments separated by fluid or blood. And then we call it pararenal extension of hematoma, regardless of the hematoma rim distance. And then grade five was main renal artery or vein laceration, including hilar avulsion, which was same. Near complete or complete kidney infarction with VCE or active bleeding, and then the multi-fragmented kidney or shattered kidney with active bleeding. So that's the overall change is that we're proposing to AAST grading and in the process of composing a new document for AST grading. So how does this affect renal trauma grading? If you looked at the 2018 versus the revised OIS 2023, and maybe it'll be 2024 by the time it's out, but here's to hoping. And you can see that a lot of grade three injuries become grade two, and then there's less grade three injuries as a whole with a lot of migration of grade four injuries. And then grade four injuries is a much smaller category, and grade five remains about the same. And looking at the modeling, the area under the curve for this set was 0.8, and the new area under the curve, adjusting for several factors, was 0.88. So much better fit, at least for bleeding risk interventions. So that's the end of the talk, and I just really want to thank all of the collaborators. I could not have done this without all these very willing trauma centers to join in this study. And one metric I should have kept track of, which I didn't, was the number of emails required to complete these studies. And it was really literally thousands and thousands of emails over this sort of 5 to 7 year period. And I really appreciate everyone responding and getting their data in. The other person that I really have to thank is Soren Kihani. He came here as a research fellow and stayed on as a research associate. And he was really the engine of a lot of these studies. And I provided steering of the car a bit, but towards the end, he was steering and the engine and really did an amazing job at pushing this work forward. The other person that I really want to thank is Dr. McAninch. And so Dr. McAninch got me excited about doing research in trauma, even when others felt like that was a dead end in the current environment. And another thing that Dr. McAninch did is he influenced reconstructive urology so much, and he created this huge network of very interested academic surgeons that really was the basis for a lot of the collaboration in this study. And it couldn't have happened without the ideas, mentorship, and the opportunity that Dr. McAninch gave me. But even more importantly, the tremendous legacy that he had in creating this group of individuals that made the studies like this possible and made turns possible and multiple other studies. So I really want to recognize Dr. McAninch and his contributions. And there is no way this study could have occurred without Dr. McAninch. So thank you very much. And I hope this was an interesting lecture for you. And it was really a pleasure to give this to UCSF, and excuse my hotel room here in San Francisco, but I thought this would be a great to record and practice for my upcoming talk.